So let's talk about a definition. Let's get into the weeds a little bit and talk about workplace violence in detail. As Ruth indicated, the definition for violence, as OSHA defines it, is very broad. And it can range from verbal abuse to physical abuse and, unfortunately, homicide and death. What you need to know is if you have a workplace violence law in your state, the state where you're working, that the law may define workplace violence a little differently. But what's important that is in the program in your facility that you have a very broad definition, that it's communicated well to staff so that you know what to report. And then we have to look at our perpetrators of violence, just to state maybe the obvious. This can be staff, co-workers, it could be a fellow nurse, a physician, your supervisor, patients, visitors, customers, vendors, or others. And if we don't report violence, if we think about this definition and it's not clear to employees, we don't know what to report. And if we don't report violence, we don't know what to prevent. And you'll hear me say this throughout this webinar, the importance of reporting. So the Joint Commission, in their workplace violence standard that Ruth mentioned earlier, that was effective for January this year, their definition of violence is also very broad. And I won't read all of this for you, but it also incorporates bullying, sexual harassment, physical assault by anyone that you come in contact with in that healthcare environment. Now, what's important especially for those of us that are nurses, is whether the patient meant to hit you, bite you, scratch you, shout at you or not. So that's intent. Workplace violence incorporates whether patients intentionally are violent or not intentionally. So if we think of all the patients we work with who have cognitive impairments, or maybe they have ICU delirium or post-anesthesia, they've had a reaction to anesthesia and they're aggressive in that post-anesthesia environment. Those with mental illness, behavioral health diagnosis, or brain injuries. I think most of you can agree that violence that's perpetrated by these individuals is usually not intentional, but it's still violence. So let me tell you a story to illustrate this. One nurse wrote that while working on an acute psychiatric unit as a nurse practitioner, she was hit by a patient with his fist to her face as she was trying to examine him for a medical condition. He broke her glasses and he gave her a black eye. She was also punched and knocked her across the room by another patient who had an anoxic brain injury as she was trying to listen to his heart and lungs to decide the treatment for his congestive heart failure. And what the nurse said was that this patient was a sad guy and he couldn't control himself, but it still hurt. And I think a lot of us deal with this almost on a daily basis. So it's very important for us to forget whether it's intentional or non-intentional in violence. Violence is violence, and we need to report it and address it. Going on to discuss the definition of bullying. This is also referred to as lateral or horizontal violence. It can also be vertical violence if you're dealing with a bullying situation between you and your supervisor or a superior or someone in leadership, for example. And, this is the definition from the Joint Commission that is a pretty common definition here. It's repeated health-harming mistreatment of one or more persons or targets by one or more perpetrators. And it can take many forms: verbal abuse, threatening, intimidating behaviors, sabotage with your work, and so on. And we're going to come back to violence a little later and how it's related to patient violence and what the research tells us. So when we talk about the types of violence, this is really a global definition. Type 1 is criminal intent, where the perpetrator has no relationship to the employer or the workplace. Type 2 is our customer or client violence. This is your patients, your visitors, your family members who become violent while you're caring for them. And then your type 3 are your co-workers, or, as I've just mentioned. They can be current or past employees, but have a relationship to the workplace. And type 4 is where we have that personal relationship. Domestic violence is a good example of this. It may be a staff person and their spouse or significant other comes to the work site and then is violent with with their partner. And unfortunately, domestic violence is increasing significantly and spilling over into our healthcare environments. Now, overlaid on this, and unfortunately just this week in Arkansas, we had another active shooter episode in a hospital in the US, and that was the fourth one this year. I'm going to get back to active shooter in a second. But active shooter, the perpetrator can fall into any of these categories. So the bottom line is that your workplace violence prevention programs must address all types of violence, including the active shooter category. So it's not just about patient violence. If you just address that, it is unlikely that the program will be sustainable and effective over the long term. So let's take a little look at the scope of violence. Ruth has mentioned some of the data. I'm going to drill down into that. And this is the data that we know today. This is changing all the time because this is a very new topic in healthcare, and the research is in its early stages. So this is a graph that gives you that kind of quick 40,000-foot view of how violence has increased in healthcare and social assistance industry. So this is hospitals, long-term care, assisted living, home health, residential care, for example. And this is intentional violence that involved days away from work between 2013 and 2020. In fact, actually, I go to 2011 there. You can see the significant increase, though, when you compare this to all other industries. And as I said before, because of underreporting, this is just the tip of the iceberg. What's happened with workplace violence during the pandemic, I'm sure most of you are aware, and this is not surprising, it has increased. One fairly small study said it had increased in 2020 as compared to 2019 by 23%. When we look at the Bureau of Labor Statistics and we compare our violence our rates of intentional and non-intentional violence between 2019 and 2020, our nurses experienced a 35% increase and CNAs an 18% increase in acute care and long-term care. So you see how significant this is. And then in one study that was conducted from February to May, and they extended it into mid-June in 2020, they found that a significant proportion of nurses who cared with patients with COVID-19 experienced more physical violence and verbal abuse and had more difficulty reporting this to management. We'll get back to barriers for reporting a little later. What was interesting, though, when they asked nurses why did they think violence occurred, the nurses in the intensive care environment said violence was due to oxygen deprivation that's associated with the symptoms of COVID-19. But in the medical surgical units, it was really associated with social political issues, such as asking patients to wear masks or their vaccination status and visitor restrictions. So it's rather sad to report that, but for a lot of you, that's not surprising. Let's look a little bit drill a little bit further into this scope and what we know right now. Healthcare and social assistant workers are nearly 5 times more likely to be injured on the job and require time away from work as a result of violence. And when we talk about injuries that require time away from work, we're really talking about severity. So this isn't just a first aid case. This is when these injuries are severe and you have to have time to recover. In a very recent survey in September this month, Press Ganey reported that 2 nurses on average are assaulted every hour in US hospitals. Now, they took this data from their national database of nursing quality indicators, and this was taken from about 483 US facilities. And when they looked at these numbers, they estimated 2 nurses assaulted per hour, that's 57 assaults per day, and over 5,000 assaults per quarter. Staggering. What's interesting to note is, in their survey, most of the violence occurred in the emergency room and behavioral health. We're not surprised by that, but it also occurred in the pediatric care environment. And from my own experience in pediatrics, I have worked with parents who are dealing with children who are very sick or dying, and they become very stressed out and can be quite aggressive verbally and physically. They don't mean to be, but if you give the circumstances, you can understand their suffering and stress and pain internally. So you have to know how to deal with that before it becomes a serious issue. What's interesting is that they said in the obstetric neonatal intensive care units, they had the lowest number of reported assaults. Males were the most frequent perpetrators. This is male patients. But in some environments, they saw that females were the perpetrators of violence. We also don't know what the rate of violence is in outpatient clinics, really in home health. We have some idea, but not a great picture. Your rehab clinics and settings, for example, or the emergency services world. So there's still a lot we need to learn. There are obviously some professionals that are more at risk for violence, such as psychiatric or behavioral health aides or techs. CNAs have a greater exposure to violence or greater experience with violence than nurses, as far as we know now. But again, this is a very gray area as related to data. What we don't know, though, is about for violence for physical therapists or occupational therapists. They work alone with patients, and they are starting to report more exposure to violence, but we really don't have good numbers related to that. Our emergency care workers, diagnostic imaging techs, for example. How about transporters? If you have transporters at your facilities, what is their exposure to violence? They often don't know if a patient's at risk for violence when they're transporting them between departments on their own. So we have some work to do. And then when we talk about the perpetrator, I've already said this is mostly the patient. And we've really got to think about a lot more research when it comes to these non-healthcare settings and what the scope of violence is and how we're going to prevent it. There are other factors that are associated with violence, and we'll get back to some of these a little later, but whether you work on evening shifts, night shifts, 12 p.m. to 12 a.m. shifts, rotating shifts, whether you work over 40 hours a week. So we don't have time to drill down to all of those factors, but we're going to give you some resources that will help you a little later. And as I said before, there's a high level of underreporting. So here's what one nurse said about reporting. I was working in a rural hospital as a night house supervisor on night shift, and I was in the emergency room helping with triage when a woman came in with a history of drug intake of uppers and downers. While trying to get her admitted, she was belligerent and fighting staff. And during that time, a staff nurse who was trying to restrain the patient, I saw her trying to restrain the patient, and the patient was about to bite that nurse. I stepped in to prevent the nurse from being bitten, and instead the patient hit me in the face with her fist. I didn't report the incident since we were expected to take whatever the patient dealt us. We're going to talk a lot about culture and how it's related to reporting a little later. But if that's your culture, that you're expected to suck it up and deal with the violence, then you've got a serious issue. Type 3 violence or bullying. I'm sure you're very well aware of the term nurses eat their young. When I talk about that to my colleagues in the non-healthcare industries, they are astounded at what I'm talking about, because bullying is typically not tolerated in other industries, but in healthcare, it tends to be tolerated. We can see that bullying occurs to new grad nurses and older nurses. And as Ruth reported, about 30% of nurses report bullying by a peer. When it comes to sexual harassment and abuse, this is a topic that is not well researched, and we haven't really talked a lot about it in healthcare, but it certainly exists. What do we know to date? That sexual harassment is very prevalent with female nurses, but I'm going to tell you it's with female healthcare workers from my experience, such as our rehab therapists. Research is in its infancy, and there's thought to be a prevalence rate of sexual harassment against female nurses of about 43%, with a range of 10 to 87%. We really don't know what the data is around sexual assault. And when I was working with the hospitals in Oregon that Ruth mentioned earlier to develop our workplace violence toolkit, we surveyed thousands of employees at 4 of the hospitals, and our survey response rate was over 1,400 staff. In one facility, 10% of the staff, not just nurses, but other direct care staff, reported being sexually assaulted by a patient. This astounded the employer, and they immediately went to work to find out more and address this. So if you are a victim of harassment or assault, please step forward, report it, get help. And we'll talk about how you do that a little later. Just to give you some data on active shooter, between 2000 and 2021, about 3.6% of active shooter incidents were in the healthcare setting, as reported by the FBI. But unfortunately, in this year alone, we've seen 4 incidents across the country. The cause of the incidents was varied. And if you're not seeing an increase in the hospitals, we're certainly seeing it in surrounding areas, especially in our cities and urban areas, where we see a lot more gun use and gang violence that spills over into our hospitals, and we have to go into lockdown. So as I said earlier, we have to address active shooter and be prepared for these awful events and how we protect ourselves and our patients. The emergency room is the most common site of gun violence, and then the patient room. There's a list of motivations here, often a grudge. It's the result of social violence, such as the gang violence in the surrounding areas, attempting to escape the facility and suicide. And most perpetrators are male, as in the case of the violence, the episode this week in Arkansas between 2 men in a hospital. We don't know much more at this time. And then most of the victims are also the perpetrator. Now, what's interesting is that 20% of the perpetrators did not bring their own firearm to the hospital. They secured that firearm from someone in the hospital. And we think about 8 to 10% of those cases, they secured the firearm from the security guard or police, if you have police in your hospital setting. And then one story, about a gun-related incident. One nurse told us, I've been in a situation where the father of one of the children in our ICU brought a gun to the unit and threatened all of us with a gun. We were fortunate enough that a staff member was able to do a silent alert for our security. They were able to subdue the father until the police arrived. No one was hurt, but we were all scared.